All right. Hello, all. Welcome to Grand Rounds for the Renal, Cardiac, and Medicine departments. Before I begin the presentation of patient X, I'd like to do a very brief review of the biochemical and physiological basics of acute kidney injury, which we will be referring to as AKI, in case it's been a while since you've thought of the rudiments. Acute kidney injury was previously called acute renal failure, but it has been found that injury to the highly metabolically active nephron segments may not result in complete renal failure, and by using failure as the marker of injury, delays in diagnosis prove to increase mortality rates. Just come on over here. All right. For this presentation, when we say the highly metabolically active nephron segments, we are referring primarily to the proximal tubular cells, which we'll be calling PTCs. If we take a look at the diagram in front of me, we see the PTC labeled on the right of the diagram. This is where we'll be focusing our discussion today. Pushing forward a bit, if you take a look at the cutout on the left of the diagram, we can see the renal medulla area. As we'll discuss shortly, the medullary area is much less sensitive to changes in oxygen saturation than the PTCs and favors the glycolytic pathway, but that's jumping ahead a bit. So just want to kind of briefly come over here. This is the medulla area that I was talking about. We're not going to be focusing on this area. We're going to be focusing on the proximal convoluted tubule cells, so right in that area. All right. Thus, for our purposes, we're defining AKI as injury to the tubular cells, which will fall under the renal etiology, as opposed to pre- or post-renal etiologies of AKI. So we're gonna come on ahead here. As mentioned, pre-renal, intrarenal, and post-renal. These are the three etiologies under which AKI can fall, which we see represented right here. The two patients we'll discuss today could potentially fall under the pre- and intrarenal etiologies, but as we're focusing this presentation on injury to the PTCs, we will look only at the renal etiologies of the AKIs experienced by patients X and Y. Excuse me. A quick note, the urine NGAL dipstick, which we'll discuss later in this presentation, one of the clinical studies under which it was used expressly excluded patients falling under the post-renal etiology conditions of ureteral obstruction and urinary tract infection. So just want to draw your attention here and here. I'm going to talk a little bit about a clinical study later on, and patients who were exhibiting either of those criteria were disqualified from the study. Okay, returning to our discussion about the biochemical basics of AKI, let's take many steps back into your educational vaults. Under normal and AKI circumstances, what is the metabolism that occurs in renal tubular cells? Dr. Okada, do you care to weigh in?
You told me not to call me that. Anyway, one of the chronically understudied metabolic pathways of the tubular cell has been that of glucose. What we do know is that fatty acids are beta oxidized, driving the production of ATP and the process of gluconeogenesis. If we look at the current slide, we see the left another map to remind us where the fatty acid oxidation and gluconeogenesis occur in the nephron. To the right, we see a schematic of gluconeogenesis that shows the formation of glucose from a non-carbohydrate molecule, a fatty acid in this case. It's interesting to think of gluconeogenesis occurring in the kidneys because we tend to think of the kidneys as filtrations and possibly degradation organs, but not usually as synthetic ones. However, if we think of gluconeogenic pathways as starting with amino acids or fatty acids that get catabolized through beta oxidation, then this process might more completely fit with our pre-existing idea of the nephrons as partaking in catabolic reactions. So, however, at the time of acute injury, instead of gluconeogenesis, the tubular cell's metabolism shifts to a glycolytic pathway. The glycolytic pathway, we are reminded by the image on the left, begins the breakdown of glucose, which means that it is more often of as the reverse reaction of gluconeogenesis. Glycolysis breaks down glucose and forms pyruvate, where gluconeogenesis breaks molecules such as amino acids and fatty acids to form pyruvate, which will be converted to glucose. I also find it interesting that injury to the tubular cells of the kidney induces a move away from gluconeogenesis because the usual response to acute stress is an increase in epinephrine and norepinephrine and or glucocorticoids, leading to increased phosphoenolpyruvate carboxykinase with ensuing gluconeogenesis. Yes.
Is that what that other diagram is showing us?
Yes.
Great, thank you.
Exactly, Aya. And your next question, all of you, should be, is this shift in pathway problematic? And if so, why? Since I'm already standing up, actually sitting down, taking Winston Churchill's advice, I'll do the work for you and answer that question. It is problematic, because if it wasn't, we wouldn't even be talking about it. No, but it is. I also want to take a brief moment to apologize. We're going to get into what I find to be some tricky anatomy and physiology for this section, and I don't have a good diagram to show. I couldn't find a good one, so just hang tight. I'm going to do my best to explain this. You guys are all a lot smarter than me, so hopefully you'll be able to make better use of this than I can. So this pathway shift is problematic because, as we mentioned before, the PTCs are highly metabolic, meaning they can produce large amounts of energy by oxidizing acetyl coenzyme A as one such pathway for energy production. They can also produce energy from the catabolism of glutamine, acetate, pyruvate, lactate, citrate, or ketone bodies. Here's where it gets a little tricky. The PTCs can regulate glucose levels by gluconeogenesis and glycolysis, but only certain segments of the PTCs can adequately perform glycolysis and use glucose as a substrate for energy production. The S1 and 2 segments are further from the medullary body, so they're more in the convoluted tubule area that we're talking about. So it's the less exposed side of the PCTs, are farther from the medullary area. The medullary area is most exposed to changes in oxygen saturation. And since the complete breakdown of fatty acids is dependent on the presence of oxygen, this segment is better equipped to facilitate gluconeogenesis than the S3 segment, which can support some glycolysis. So let's take a beat and think about what I just said. So the S1 and 2 segments are further from the oxygen saturation change area. So those are the segments that do best in facilitating gluconeogenesis, whereas the S3 segment, which is closer to the medullary body, can support glycolysis better than the S1 and 2 segments. So S1 and 2 segments, more protected from changes in O2 saturation, which is necessary for the complete breakdown of fatty acids for gluconeogenesis. The S3 segment is closer to the medullary body, so it's more capable to handle changes in oxygen saturation, so it is more capable to handle glycolysis. So you've got S1 and 2 segments, that's 2 segments I'm talking about for gluconeogenesis, and S3, so just one that can better facilitate glycolysis. So that's why you'll see that the shift from a gluconeogenic pathway to a glycolytic pathway is problematic. Also, because the tubular cells are the most abundant cells in the nephron, have sensitivity to oxygen saturation, as I just said, and have a high level of metabolic function, the alteration of glucose metabolic pathways is important to understand in gaining a working knowledge of the pathophysiology of AKI. Again, since glycolysis is not preferred by the PTCs, the switch can result in, amongst other things, pyruvate depletion glycolysis intermediates accumulation, and glycolytic enzyme upregulation. All bad things for this particular area of the nephron. Okay, thank you.
Now that we have a quasi working understanding of the pathophysiology surrounding AKI, I want to take a moment and talk about the current standard of practice for diagnosing AKI. So AKI is currently marked by the decreased filtration by the kidneys, also called the glomerular filtration rate, GFR, and an ensuing increase in the amount of nitrogenuria and creatinine in the patient's blood. Therefore, if you look at the little dial on the right, you will see that an inverse relationship between the GFR and the serum creatinine levels to be expected. Serum creatinine has been the gold standard of AKI diagnosis despite its known limitations, namely the fact that there is often a delay between onset of an injury time and increase in the creatinine level. So what is creatinine? If you take a look at our current slide, we can see the synthesis reaction for creatine on the top image. You may be remembering it as a protein, but it's actually not. It's a nitrogenous compound that gets produced by muscle creatine degradation. Creatine, to remind us all, is an amino acid found primarily in the muscles and the brain. Creatinine, as I mentioned, is a byproduct which will be present in the serum, plasma, and urine, and is excreted by the glomerular filtration at a constant rate and in the same concentration of the plasma. It would then make sense if a patient has injury to the kidney cells, which we know have the primary physiology function of filtration. Byproducts such as creatinine would not be able to be cleared and thus would build up in the body.
In a moment, I would also like to do a quick summary of the conversion of creatine to creatinine. Just wanted to quickly reiterate what I said before. So glycine, L-arginine, we're going to form guanidinoate acetate, and then creatine gets methylated. This addition of this methyl group is what makes creatine. Okay. So kidney synthesis of creatine, as I just said, begins with the amino acids arginine and glycine, which are nonpolar and polars, respectively. Creatine synthesis also requires enzymes, bear with me, glycine amidinotransferase, also called AGAT. Let's have a look here. Oh, great, it's not on this one. Okay, no problem. And guanidinoate acetate methyltransferase, again. The methylation. Quick reminder, if it's a transferase, what does it do? For all of you guys who haven't thought about this in a million years, if it's a transferase, it's an enzyme that facilitates the movement of functional group or groups. And that's called GAMT. The first enzyme that I mentioned, that I garbled the name of, AGAT, produces guanidinoate acetate acid, which that sounds incorrect to me, but I double checked that. That's called GAA when it reacts with L-arginine and glycine. GAA gets methylated, and creatine is produced. Okay, so if creatine is being produced de novo, the synthesis is occurring in the liver, pancreas, and or kidneys. Because you all probably remember that you can take in creatine exogenously, namely through the consumption of meat and fish, but we can also produce it endogenously, which again is what we see up here. So once the creatine has been produced, let's say for our purpose by the kidneys, it's circulated to other organs, as I said, mainly the brain and muscles. At these target organs, this is where the fun stuff happens. It gets phosphorylated by the enzyme creatine kinase. Again, reminder, it's a kinase, so a phosphate gets added on. After CK phosphorylates creatine, creatine becomes phosphocreatine, which, because of the addition of the phosphate ion, is a high energy molecule, and we see that down here. So we start with creatine. Creatine kinase is going to grab an inorganic phosphate from ATP, so we're going to get a release of ADP, and this is phosphocreatine. In the meantime, creatinine is created as basically a byproduct of this conversion reaction. So it's during this CK catalyzed reaction, conversion of creatine to phosphocreatine, that the byproduct creatinine gets created. Another reminder that creatinine is essentially a waste product, and thus if glomerular filtration rate, so GFR, falls, serum creatinine should rise, as I had said in the previous slide. Okay. Here we have patient X. So now that we've covered about 13% of the biochemical basics of AKI, let's return to our patient. So please meet patient X. He is a 55-year-old Caucasian male who presented to the emergency department, the ED, on 11/26 with chief complaints of angina, dyspnea, and fatigue. You're going to hear a little snippet of a poorly conducted interview between myself and patient X. He definitely seemed to be stressing his experience of angina. Okay, let me let you have a quick listen to him.
Hi, Mr. X. Can you please tell me what's bringing you in today?
My car.
Not how you got here. What's the problem? What's going on with you physically?
Oh, me personally. Well, aside from shortness of breath and generalized feeling of weakness and tiredness, it feels like something's really heavy sitting on my chest.
Does your chest hurt?
It hurts like it's being crushed. Yeah, it hurts a lot. But aside from that, I'm pretty okay.
Okay. Are you taking any medications right now?
No. No, I'm not.
Okay. Great. Thank you.
Oh, awesome, wonderful. Okay, so you heard his chief complaints. So what did we do? Labs were immediately drawn with special attention paid to his troponin and serum creatinine levels. We drew that troponin, namely as a result of his complaint of angina. As you know, anytime you come in, chest pain, shortness of breath, you are getting troponins pulled, because troponin in the blood is, we'll just kind of basically say, is usually an indicator of cardiac muscle death. So we'd be looking for for heart attack. Okay. After finding both levels to be elevated and his EKG to show irregularities, he was taken to the catheterization lab for imaging. Here he underwent angiography, which showed blockage of the left main coronary arteries to the LMCA and valvular stenosis. So let's have a look. All right. Left main coronary artery occlusion. Sorry, I'll come over here. He had tricuspid valve stenosis, so we know that a stenosed valve is one that cannot open or close all the way. Usually the issue is closing all the way, so we get regurgitation into the previous ventricle. I don't want to give away the ending, so I'm going to leave those two for a moment. So as you all know, the course of treatment for LMCA blockage is coronary artery bypass graft surgery, so long as the patient is a good candidate for surgery. Patient's tricuspid valve was found to be stenosed to such an extent that it required replacement. A bovine donor valve was chosen after consideration by the surgical team. So now I can give it away. So bovine valve, quick note of interest or not interest for all of you. For a pig valve, the actual valve is taken from the pig and used. Same, obviously, for a mechanical valve, they just build a replica of the valve. But because cow hearts are so large, human body is not able to accommodate a cow valve, so we just use tissue from the bovine, like cardiac cells and pericardium, and we build a valve from that, which is very cool. Also, a lot of people tend to prefer a bioprosthetic valve to a mechanical valve because you don't have to continue to take Eliquis or blood thinner. So for patients such as Mr. X, who may want to have children, a bovine or porcine valve is going to be a great option for him. The only thing is they tend to wear out a little bit more quickly than the mechanical valves. So in addition to his valve replacement, he also underwent CABG. So we bypassed his coronary artery that was blocked. We took a vein from his leg and performed that surgery. All right, so at this point, the patient's outpatient cardiologist had also been consulted. The usual preoperative testing followed, including urinalysis, CBC, so that's complete blood count, and PT, PTT, which is platelet timing tests, as well as repeat serum creatinine. On repeat testing, serum creatinine levels were found to be outside of the normal range, which is 0.74 to 1.35 milligrams per deciliter for a male. His level was found to be 2.02 milligrams per deciliter. Nephrology was consulted regarding the possibility of cardiac-induced AKI. Sorry, so this takes us to approximately 3 hours post-ED presentation. I know none of you believe me. Lucky for patient X, his discomfort got the best of him on a Wednesday morning, avoiding the unfortunate plumber's Monday scene in the ED. Patient was taken to the surgical waiting area and prepped for surgery in the usual fashion. Intraoperatively, everything went well. Patient was given 8 units of packed red blood cells due to a history of Eliquis use, I believe for atrial fibrillation. After the procedure was completed, patient was assessed in the the post-anesthesia care unit, so the PACU, before being transferred to the cardiac floor. Post-operative labs were drawn every 4 hours in the 48 hours following surgery. At 4 hours post-op, serum creatinine levels were measured and found to have fallen to be within normal range at 1.3 milligrams per deciliter. Despite serum creatinine levels being within normal limits, since our hospital has been implementing the use of NGAL testing at bedside for AKI, we dipsticked the patient. Urine protein NGAL was present in the patient's urine despite his non-elevated serum creatinine results. Nephrology was consulted regarding diagnosis and treatment. Based on the fact that this patient had a history of cardiac events and valve replacement in addition to the CABG, which, as you may also know, has been shown to increase incidence of perioperative AKI in cardiac patients when compared to CABG-only surgeries. We proceeded under the assumption that this patient had AKI. Nephrology did, however, continue to order serial serum creatinine levels. It must be noted that his levels did not appear outside of normal limits until approximately 24 hours post-operatively, and we dipsticked him at 4, just to remind you. And myself and I are going to go into more depth shortly about the NGAL dipstick process and NGAL in general, so hold tight. So due to his diagnosis by NGAL dipstick, he'd already begun treatment for AKI. Just anecdotally, I know of at least one other patient with similar lab values who was not tested for NGAL and was moved to the regular medicine floor instead of the medical intensive care unit, so the MICU. Delaying diagnosis and treatment proved detrimental for this other patient. Patient X, however, was hospitalized for a total of 13 days before discharge to cardiac rehab, where he stayed for another 7 days before returning home. His post-operative time has been unremarkable, and he continues to be followed closely by cardio and nephrology. Are there any questions before I proceed in getting to what I feel to be the meat of this presentation? No? I put you to sleep. Okay. Then moving on to the wild card component of this patient's case. Did he have AKI preoperatively? Would it have mattered what we found preoperatively in regards to his post-operative renal care? What about post-operatively? Why did we begin treatment post-operatively, even though his serum creatinine levels were within normal limits? I sort of talked about that last one, but let me go to the next slide here. Okay. So, briefly, to answer my own questions before, we're not certain whether or not he presented with AKI, despite his increased creatinine level of 2.0 milligrams per deciliter. At this point, you're asking, isn't serum creatinine testing the standard of care in diagnosing AKI? Yes and no. As I had discussed before, we've known for some time limitations of serum creatinine as a biomarker because of its instability. By instability, I mean that a patient may not have elevated serum creatinine levels until 24 to 48 hours post-injury for AKI, as was true for this patient. This is a good place to note that while we've been focused on the delay in increased serum creatinine levels after AKI, there's also instability in the direction for like a false positive of an increased creatinine levels. I mean that because of stress that could cause hypoperfusion, but not injury to tubular cells, serum creatinine levels may sometimes show a spike, followed by a very quick return to baseline levels. This may result in patients' unnecessary transfer to the MICU, using up a precious MICU bed, which is not a good business plan. Returning to our patient, we did see the presence of NGAL. What is NGAL? Neutrophil gelatinase associated lipocalin. So we found this was present in his urine after only 4 hours post-op. I can see all of you squinting, trying to recall the last up-to-date that you read that mentioned NGAL. Turn your attention to the screen. Here's a refresher. So here is the 3D structure of NGAL. So we'll see, just as a reminder for all of you who don't remember biochem, we see some loops and turns. We see some anti-parallel beta-pleated sheets, some alpha helices. I'm sure there are some domains that I'm not pointing out, but this is our tertiary structure up here at this corner. So NGAL is a 178 amino acid long transmembrane protein, usually found in the neutrophils and epithelial cells of the proximal convoluted tubule. So if you're hearing neutrophils, you're thinking something to do with inflammation response. I'm thinking that's probably where your thought process is going. One of its proposed functions is to regulate the expression of caspase 3, which is a frequently activated death protease. Also, brief aside, NGAL is resistant to protease degradation. Obviously, that's why it just shows up in the urine. There we go. But caspase 3 is a frequently activated death protease. And so NGAL will regulate the expression of this in injured renal cells to protect them from apoptosis. Okay, so there continues to be debate regarding the specificity of NGAL as a biomarker for AKI, as it's not specific to the kidneys. In addition to being detectable in urine, it can also be detected in serum, but possibly because of the way the protein is metabolized, serum, so S-NGAL, may be less specific for AKI diagnosis than urine, so U-NGAL. Metabolism is also affected by the form the protein is in, so the monomeric form being able to be excreted much faster than the dimeric form. Further refresher for you PGY20s out there who have not, for real, used your brain in about 17 years. The dimeric form of a protein may be made of 2 single proteins or monomers. The gene that codes for NGAL has been studied and found to be upregulated after kidney injury, including after kidney cell ischemia following bypass used in cardiac surgery. Another quick factoid to keep the CT guys awake. The time and length of bypass, in addition to having implications for kidney cell ischemia, may arguably be the most important indicator of blood transfusion that's required during any given surgery, and we all know we're trying to decrease the need for transfusions during cardiac surgery. You probably can't see too well what's going on here, but we see that NGAL gets induced after renal injury. So we see that over here. We also see that NGAL induces conversion in epithelial cells. Again, a bit hard to see it on here, but that's what we've got going on. Okay, I'm going to turn it over to my co-provider, Aya Okada, who will be presenting the facts of the case for patient Y, another individual who was assessed for AKI amongst other issues. This guy was in pretty rough shape when he rolled in. All right.
Hello all, thank you again for being here. It's so important to get together and discuss our more challenging cases. So this leads me to introduce you to patient Y. Patient Y is allegedly a 43-year-old Caucasian male who presented to our ED on a Friday evening at 19:45. He arrived alone via taxi, complaining of dyspnea and tachycardia. He was triaged there, where his vitals were taking, and was found to be tachy at 140 beats per minute, febrile with a fever of 39 degrees Celsius, dysphoretic, and exhibited altered mental status, as you can see. We immediately drew labs, complete blood count, CBC, serum lactate, reactive protein, serum creatinine, and procalcitonin, as well as alcohol and tox screens because of his altered mental status, which was making him a poor historian at the time. Alcohol and tox screens were negative. His serum creatinine were within normal limits. His serum lactate was slightly elevated, as well as his CBC. We're now about 2 hours post-ED presentation for Mr. Y. We've given him some IV fluids and 100% oxygen via his nasal cannula to try to make him more comfortable, but he does not seem to be improving. So at this point, we're trying to contact family and find any recent hospitalization or changes for our patient, but are not successful in doing so. However, upon physical examination, one of our residents took note of a tattoo on his bicep that looked new, as you can see in the red pointed marker right here. Now we start to think maybe this patient was septic and at risk for septic-induced AKI. So we ran some labs, and his serum creatinine continued to be within normal limits, despite a decreased GFR, an indication of a protein NGAL in his urine. We saw that the patient had a high measurement of the UNGAL dipstick, which is another indicator of septic-induced AKI. According to one of the studies, a high dipstick measurement can be translated to an odds ratio of 16 for the probability of a septic AKI. So these markers were enough to convince us to transfer him to the MICU and start treatment. So serum labs were drawn while he was in the MICU, and serum creatinine levels did not appear elevated. But this may have been due to the fact that in addition to the antibiotics, we also started him on resuscitation for AKI. Fluid resuscitation is indicated by poor renal blood flow and decreased intravascular pressure. If we look at the diagram on the right, we can see that the fluid imbalance is a big issue when dealing with AKI. It makes sense for a patient such as Mr. Y. Sepsis leads to low blood pressure, which correlates to low vascular pressure, decreasing GFR. Obviously, when GFR falls, protein and other molecule metabolisms also slow down. So when this happens, we see the metabolic byproducts such as creatinine and blood urea nitrogens present in the serum. So with regard to other biomarkers such as insulin-like growth factor binding protein 7 and tissue inhibitors metalloprotease 2, we see the release into blood and urine in addition to that of NGAL, because these proteins are associated with cell cycle arrest, which occurs with tubular injuries. So flood recursion aims to right the fluid balance in the renal system that has been damaged by sepsis or cardiac ischemia, to name a few reasons. So returning to patient Y, he's currently 3 weeks post-op ED presentation and has been moved from the MICU to a step-down unit. His AKI and sepsis were identified early enough that he did not end up requiring dialysis. Good for us. Due to the progression of infection, we can assume that if he had waited for serum creatinine levels to be elevated, instead of using the UNGAL as our green light for treatment, the patient may have required a more aggressive treatment such as dialysis. I also wanted to quickly mention that lateral flow dipstick were used at the bedside to test for NGAL. The result of the bedside testing were then validated using ELISA and Western blot testing. So thank you all for taking your time out of your schedule to listen to these presentations. We hope to have convinced you to take a closer look at alternative biomarkers for AKI in the hopes of earlier diagnosis and treatment.